Well, hi everyone. Thank you so much for joining tonight. My name is Minali Nigam. I am one of the headache fellows at the John R. Graham Headache Center in Boston. I completed my neurology residency from Mass General Brigham, which is affiliated with Harvard Medical School. I'm very fortunate in my training that I actually get to work at a CSF leak clinic that we have here at Brigham and Women's, and I work with my attending Dr. Shuhan Zhu, who started the clinic. And so it's my experiences rotating through the clinic that I created the presentation today, and I hope that it can be informative for you. So the topic of today's talk is going to be, could I have a low pressure headache? We also call this type of headache spontaneous intracranial hypotension or CSF leak headache. So just to give basic anatomy of what we're talking about here in terms of what do we mean by CSF leak. So cerebrospinal fluid is a protective fluid layer that surrounds the brain and the spine. There are multiple layers that are protective for the brain and spine. One of those layers is called the dura. So as we can see here, this area is the spinous process. And then as we get deeper in, there are other layers. This right here is the dura. And so if this layer gets torn or broken, then a lot of times we'll find that the CSF, which is right here, can leak through there and create issues. Just one point to know about CSF leak. So even though the title of this talk is low pressure headache, that's a misnomer. A lot of patients who have CSF leak headaches can actually have normal pressure or high pressure when we do a procedure called a spinal tap. And so this is the spinal needle that we use in a spinal tap, and it collects CSF fluid. Just other layers to go over briefly. So here you can see some of the spinal cord and the nerve roots that are coming from here, and then the vertebrae. So the layer that we're talking about, again, with the CSF leak is right here, right below the dura. And so how can a CSF leak happen? So we think about post-surgical CSF leaks that can happen after a spinal tap, or sometimes post-operatively after a spinal surgery. Trauma can also induce a CSF leak. And then we also have spontaneous CSF leaks. And majority of the talk is going to focus on spontaneous as opposed to post-surgical or post-dural puncture headaches. We think about three different anatomical structures that can cause spontaneous CSF leak. Type 1, we consider a dural tear. So if you look right here, this is a bony spur that basically comes from the spine. So you'll see sometimes in our radiology reports degenerative disc disease or bone spurs or calcifications. And so what can happen over time is the bone spur pokes through the dura and it can create a leak. Type 2 is what we consider meningeal outpouching. So the meninges is another protective layer around the brain and the spinal cord. There's an outpouching. Sometimes that can also lead to a CSF leak. And then type 3 is when there's an abnormal connection between the vein that can go in near the spinal cord as well as the dura. So if there's like an abnormal connection here between the spinal CSF and the vein, that can also lead to CSF leaks. A quick note is that CSF leaks can happen from the skull, and that's usually in the setting of trauma. So patients can have like a runny nose or fluid that's coming out of the ear. They're very rarely associated with this type of headache, though, in terms of the intracranial hypotension. We predominantly think about CSF leaks that are associated with this headache coming from the spinal cord as opposed to the skull. So who can get CSF leaks? So contrary to what the general population might believe, this is not a rare condition. In the literature, just looking at some of the epidemiology that we have, 3.8 to 5,000 people per 100,000 are estimated to have this condition. It is female predominant. We don't have an exact known reason why. It's about 2-to-1 ratio. And the highest prevalence is specifically within women between the ages of 35 to 55 years old. There is a risk with certain hereditary connective tissue diseases. So for example, Marfan's, Stanlow's, joint hypermobility. And just thinking about the overall impact of CSF leak headaches. So in some of the studies that have been done, they've shown a lower quality of life score both in terms of spiritual well-being when you compare to patients who have cancer, AIDS. A lot of patients will experience depression. And then the piece that we often don't talk about are the financial and social challenges that come with a condition like this. So in one study, on average, about 1/2 of the patient population with this condition reported having to leave work for more than 3 months. 1/4 of the patients in that study weren't able to return to work because of just how debilitating the headache was. And then there's also a lot of interactions that happen within the medical system. Unfortunately, it can often take a long time to get in to see a specialist. And then even then, on average, it can take about 3 doctors to get to a final diagnosis. In one study, it showed it took patients at least 2 months to make the diagnosis. And 45% of the neurologists that saw those specific patients did not get the diagnosis at the very first encounter. So a lot of challenges that can come with living with the condition, but then also getting a provider who can make the right diagnosis. And so how do we make the right diagnosis? And I think this is the part where history taking is key. So a lot of headache medicine is specific to what the providers ask our patients and the information that the patients provide us. And so the key part of the history for this kind of headache is finding out if there's a positional component to the headache. So if there is an orthostatic component, essentially, does the headache get worse when you're sitting upright or standing up, and does it get better when patients are lying down? About 90% of patients will have this orthostatic component to the headache on initial presentation. A lot of times providers will not ask the right questions to get this crucial part of the history. So oftentimes what I'll ask patients is, okay, like when you stand up, how soon after do you experience head pain? Some patients won't notice a change until it's about 30 minutes to a couple of hours. Some patients will report, oh, I'm fine in the morning, but then it gets worse throughout the end of the day. But the key part of this history taking is finding out, does the headache get better consistently at a specific position, meaning lying down, and does it get worse when standing up or sitting upright? So getting that consistent headache onset and offset is really key. And sometimes the providers won't ask you. And so it's important from a patient perspective to try to be able to give that information to us. The challenging part of this is a lot of times the orthostatic component of the headache will diminish over time. So if you're not able to see a provider, or if you're not able to get in to see a provider for a few months, it may be that the orthostatic component has become less and less as time has progressed. So it is important for both the providers and the patients to specifically recognize, what was the headache like on onset? Was there an orthostatic component when you first had the headache? And what was the pattern change over time? So sometimes that orthostatic component won't be there a few months down the line, but it is important to get the initial history of what was your headache like when you first experienced it. Other symptoms that patients can have, so certain hearing changes. Some patients can get tinnitus or ringing in the ear, muffled hearing. There can be neck pain, dizziness, imbalance issues, and nausea. Sometimes patients will have a headache that's only at the back of the head. Sometimes it involves the full head. Really a range of symptoms outside of just the orthostatic component of the headache. Less common, and usually these symptoms sort of present later on, so if patients aren't diagnosed right away. But we can see different cranial nerve deficits, cranial nerves being the nerves that innervate the face. So facial pressure, double vision, people can get abnormal sensations on the face. And then over time as well, people can develop certain cognitive changes, behavioral changes, trouble talking, swallowing, and in some cases, coma as well. So why do we think we have these symptoms? What's the pathophysiology or underlying mechanism of this? So for some of these symptoms, like the cranial nerve deficits and headache, essentially what happens is that as that CSF is leaking out, the brain structures get displaced and sag downward. And so it's that displacement and sagging down effect where we think it can affect some of the cranial nerves. And then the sagging and displacement can affect certain nerve endings within the dura as well as the vessels. So that's what one reason of why we think that patients with CSF leaks get headache in the first place. How do we diagnose this condition? So we use a few different diagnostic tests. So obviously the most important piece is getting the clinical history and the symptoms that a patient is presenting with. But then after that, if there's questions of, is there really an orthostatic component? What is the severity level, like sitting down versus standing up versus lying down? If we can't get a very clear answer on if there's an orthostatic component or not, at least in our clinic, we will have patients complete a 48-hour tilt test. So for practical reasons, some patients can't just lie in bed for 48 hours. So sometimes they'll shorten it to 24 and do a modified version of it. But essentially what we'll do is we'll ask patients to record some baseline symptoms before getting into bed. Usually it's like a Friday night. And we'll ask them to rate on a scale of 0 to 10, 0 being like no headache, 10 to being very severe headache and like other symptoms, so nauseas and this on this scale, like ringing in the ears, vision problems, just basically a list of various symptoms rated on a scale of 0 to 10. So 1 is like on a Friday night before they get into bed, and then on Saturday morning, we'll ask patients, you can get up, go to the bathroom, and then go back to bed. And then we'll basically ask patients to record what their symptoms are like when they're in bed for 24 hours to 48 hours. And then once they get upright, we'll ask them to again rank their symptoms on a scale of 0 to 10 once they've been up for 3 hours after being bedbound, essentially. And it is helpful if we see a significant change in these numbers between lying down versus standing up. It can help direct us in getting further testing to better clarify if someone does indeed have a CSF leak. And so a standard part of the workup that we do is getting brain MRI with contrast as well as spinal imaging with contrast. There's various different types of findings we can see with an MRI brain with contrast, just to highlight a few of these on what your doctor could be mentioning. So one I had talked about already, which is basically the displacement or sagging of the brainstem structures. So right here is the back of the brain. You can see it's displaced slightly when you compare it to a normal image. Some of the veins can also enlarge because, again, some of that CSF fluid is leaking. So the brain structures are shifting, including the brain, including the veins. And so the veins are enlarging here as well. Sometimes we can see patients who develop brain bleeds, like subdural hematomas. And then this area right here is the pachymeninges. So this is called pachymeningeal enhancement. You can see a normal one here. This here is abnormal. And so we can see that in patients who have intracranial hypotension or CSF leaks. And then a few other findings we can see: the pituitary gland can get larger. And so one of the hormones that are secreted from the pituitary gland, prolactin, can be elevated in patients. And then lastly, sometimes these optic nerves. So this is normal. You don't see any enhancement here. The optic nerves here are enhanced, and you can see that sometimes with patients who have CSF leaks. In terms of spinal imaging, this is really key in terms of identifying a site of the CSF leak and can be used to help us with targeted treatment. So we get an MRI of the spine, and it's specific dedicated sequences that we need to see with the MRI spine. So just a general full MRI spine isn't going to cut it in terms of really properly assessing for a CSF leak. It has to be done with a special protocol. We have to be able to see the lateral epidural space to see if there is indeed actually a leak. So we put in a formal specialized protocol when we get these MRI spines. The second type of imaging that we can get is a CT myelogram. Essentially what happens is we'll inject a dye into the CSF space and then get x-rays. And usually there's a delay between when we inject the dye and when we get the x-rays and the CAT scan. And then the last type of imaging that we get is called a digital subtraction myelogram. Sometimes we don't need to get this, but if the MRI spine and the CT myelogram are normal, but we suspect that there could be a fistula or the abnormal connection, we will get a digital subtraction myelography. The fistula won't be visualized on the other two imaging modalities. And so the way that the DSM works is that we inject the dye, same into the CSF space, but instead of having a delay on when we get the x-rays, we get the x-ray right away. Unfortunately, this specific imaging is not available at all centers. Usually it's a very specialized center that has availability, and you need to have a neuroradiologist who can interpret this type of imaging. And so it's not readily available everywhere. One pro in terms of the CT myelogram is that you don't expose the patient as much to ionizing radiation. But again, the digital subtraction myelogram is a little bit better and more specific in terms of imaging modalities. And all this to say, sometimes we do have patients who will have completely normal imaging, but still have a presentation of what we suspect is a CSF leak headache. So about 20% of patients don't have any abnormalities on imaging. And just one other thing to note about the diagnostic workup is that sometimes people will get spinal taps or lumbar punctures, though that's not a standard of practice that we use in our clinic. It is part of the criteria that we use in our headache guidelines. And the reason that's there is for resource limited areas that don't have these types of imaging modalities. But like I mentioned on the spinal tap, it's not necessary for patients to have low pressure. Some patients will have normal pressure or higher pressure even when we do the spinal tap. So it's not a specific test for diagnosing CSF leaks. So how do we treat this condition? So, we do try to do some conservative measures. Earlier treatment, the better. And so in terms of conservative treatments, we'll counsel patients to try to take caffeine. I'm sure some of you have heard to try to consume as much coffee as you can in a day. So the recommended guidelines is between 300 to 500 milligrams. So that roughly estimates to 3 to 4 cups of coffee. The mechanism isn't totally clear on why caffeine works for this type of headache, but it's thought to basically stimulate the choroid plexuses in the brain. These are essentially the choroid plexi produce CSF. And so the thought is that you increase CSF production. We recommend patients to hydrate. So we'll recommend between 2 to 2.5 liters of water per day. We do recommend bed rest, avoiding like straining. And so trying to avoid constipation as well. And then sometimes we will recommend an abdominal binder to help with that orthostatic component. Usually we won't do conservative treatments for more than 2 weeks. Beyond that, we really do start thinking about more procedural interventions. Briefly, I'll mention just some medications before talking about the epidural blood patch, which I'm sure many of you have heard about before. But in terms of medications, there's really not good evidence for any of these options. For some patients, it can help partially relieve the pain. A lot of the ones mentioned here are specifically for the post-dural puncture headaches. So this is the headaches that happen as a result of a spinal tap or surgery. So for some of these patients, gabapentin provides minimal effects on the short term, long term, not so much. Same thing with steroids and antidepressants. Sometimes patients will get occipital nerve blocks. But overall, there's not strong evidence anyway to suggest that any of these medications are particularly effective. We do try to avoid medications that could lower the CSF pressure. So specifically topiramate and indomethacin are 2 medications we try to avoid. And if possible, we try to avoid blood pressure medicines that could worsen some of the positional symptoms. But of course, we have to take each patient's clinical history into context. So depending on blood pressure goals, we may have to keep patients on certain blood pressure medicines, but really depends on the situation. All right, moving to the epidural blood patch. What exactly is this procedure? So essentially, what it involves is having a blood sample injected into the spinal fluid space. So what we do is we take blood, and it's usually from the patient's forearm, somewhere on their arm, and then we will inject that blood into their spine. Usually we'll inject about 20 to 40 cc's of blood into the spinal fluid space, or until the patient says that they have back pain. Once they report back pain, we will usually stop the injection. And so as you can see here, this is the injection area. The way that this is thought to work is basically it forms a clot, and so it stops the leakage coming in from the CSF. So if there's a punctured dura, the thought is that there will be a clot that forms around the puncture site to avoid further leakage. So there's non-directed therapy and targeted therapies. So with the non-targeted, usually the proceduralist will try to inject in the lower spine. Targeted therapy, so this is really where some of that spinal imaging comes into play. If we see a specific CSF leak site, we will target the injection there. And so that's usually when we'll target more of the upper spine, the cervical or thoracic spine. Patients can have multiple patches done at once. It really just depends on the patient's specific situation. I will say for the post-dural puncture headache, so after the procedure, after a spinal tap or surgery, we can offer epidural blood patches. Typically, we'll offer it if the headache lasts more than 2 days or it persists over 4 days without any significant improvement. And you know, of course, we'll offer this for patients who have the spontaneous intracranial hypotension as well. A few precautions that we share with patients after getting the procedure: we recommend lying flat for as long as possible and not driving 1 to 3 days post-op, and also minimizing certain strenuous exercises, lifting weights, bending, constipation for at least 4 to 6 weeks to really try to get optimal effect of the blood patch. Some risks of this procedure do include back pain. You know, we're injecting blood into a site where blood normally isn't. So it can cause irritation. Sometimes patients will get rebound headache. So this is a type of headache that essentially is the opposite of a CSF leak headache, where patients can get worse headaches when lying down, and then sitting up or standing, they'll get improvement in their headache. Not all rebound headaches have that positional component. Sometimes it's just a different type of headache. But in these cases, sometimes we will actually give CSF lowering agents like topiramate and Diamox temporarily, just to help for that immediate onset of rebound. And usually the rebound headache will come within 48 hours of the procedure. Anytime we inject needles, there is a risk of infection as well. And you know, unfortunately, sometimes we can actually cause worsening of the CSF leak if there is an accidental puncture through the dura when we're doing this procedure. Another medical intervention that we can offer is the fibrin glue patch. So this is an option that can be available for certain patients. We can't inject their own blood. So this is great for cancer patients, patients who have any bloodstream infections, or patients who just have really difficult venous or arterial access, and we can't stick to get blood. So a fibrin glue patch is another option. Essentially what this is plasma products that are derived from human donors. So it's a mix of human fibrinogen and thrombin. Essentially, the combination of both of those creates the fibrin, which is the element that causes the clot around the CSF leak site. Again, we inject it into the epidural space. You don't need to inject as much volume of the plasma product as you do of the blood in the epidural blood patch. There are risks involved with this procedure as well. If the fibrin patch is accidentally injected into one of the blood vessels as opposed to the epidural space, it can cause a clot in the blood vessel. Some patients can get allergic reactions to in the injection site, and then because we are dealing with human products, sometimes there can be transmission of undetected viruses from the human donors. And then usually reserved for the last line of treatment is surgery. For some patients, we will offer it, before some of these other procedural interventions. But there's different type of surgeries that neurosurgery can do to help with CSF leak headaches. So one is direct repair. So going back to the type 1 spontaneous CSF leak. So this is caused by bone spurs or jutting out or the vertebral discs. So sometimes neurosurgery can just remove the bone spurs. Other times they can actually stitch up the hole or the tear within the dura itself. Indirect repair involves applying a graft or glue to reconstruct the dura. For fistulas specifically, they can embolize the fistula, basically like block the abnormal connection. And then they can also put in sutures or metal clips to help to basically disconnect the abnormal connection as well. It's important to get treatment as early as possible because there are complications that can happen if we leave the CSF leak untreated. So I did mention, brain bleeds like subdural hematomas that can evolve over time. There can be clots like venous sinus thrombosis that can happen if we leave the condition untreated. Patients can get into a coma eventually as those brain structures continue to sag and become displaced. And over time, we can also see a finding called superficial siderosis. And essentially what this is deposition of iron within the brain. And so this can create a host of neurologic problems, including gait difficulties, cognition difficulties. In one study, it did find that patients who went 4 years without treatment for spontaneous intracranial hypotension had 5% of them had this finding. At the 16-year point, 58% of them had this finding. So, it is important for us as providers to recognize this diagnosis and to initiate treatment as soon as possible. So here in our CSF leak clinic, what we try to do is actually place referrals for epidural blood patch as soon as possible. Once we suspect and or confirm on imaging. And so we'll place the referral for an epidural blood patch within 2 to 4 weeks and also start conservative treatment with the caffeine, with the abdominal binders, with the hydration, just to get the process going. In terms of repeating blood patches, so in the literature, it's variable, the exact number based on the specific study, but about half of patients will respond to the first epidural blood patch that they get. This is for spontaneous, the CSF leaks. About 1/4 of patients will respond after the second blood patch, and then another 1/4 of the patients will either respond to 3 or more blood patches or another intervention. A small percentage of patients won't be responsive to any of these interventions. And so if we do need a repeat blood patch, we usually space it out at least 2 months from the first blood patch. In terms of repeat blood patches and further interventions, it's all largely based on symptoms. So if a patient comes in and they're still having that positional aspect of the headache, even after the first epidural blood patch, that's when we'll consider a second one. A lot of it also depends on how disabling the pain is. And so it's really variable by patient, but we usually try to get at the heart of, is the headache that the patient having a rebound headache, meaning a post-procedure headache, or is this truly the CSF leak headache that's ongoing and hasn't been completely responsive to the blood patch? And so it's really important, again, to tease out that history, the clinical history and the exact symptoms that the patient is experiencing. We do recommend regular follow-up with a neurologist or headache, especially while the symptoms are ongoing. We try to schedule patients at least within 3 months, and then, hopefully more frequently if needed. And then there are patients who have graduated our CSF leak clinic. Their symptoms have completely resolved after the first blood patch. We see them again in follow-up once, and they no longer need us because, their headaches have completely resolved. And just a quick point about repeat imaging. We don't do it routinely for our patients. We will do it, for example, if we see like a subdural hematoma or a brain bleed, and not all patients need follow-up spinal imaging. We will do it in some cases if we need to just clarify, if we didn't find the exact CSF leak site, we can repeat imaging. We'll try to do it within 3 months of intervention, sometimes sooner, depending on the case. But really, we guide our repeat imaging and repeat procedure based on if the patient has ongoing headache symptoms or not. And I'm happy to answer any follow-up questions. I did want to put in a quick plug. So the Spinal CSF Leak Foundation has wonderful patient-centered information on their website. They're a great organization. Ironically enough, they are having a conference in Colorado, both with patients and providers. It's in 2 weeks. It is free for patients. So if you have the time and are available, I highly recommend going. I think it would be even more informative than this talk. But thank you so much for giving me the opportunity.